Hi everybody, welcome to QuickSTEPs. This is our first of our Derm question series, and it's one of the first videos that we're going to be putting out. We will be focusing on how to approach these questions. Our goal is to make this algorithm second nature for you. It will save you a lot of time and get you a lot of points come test day, while we're also going to be covering high-yield Derm concepts. Anything not covered in this video will be covered in subsequent videos. Our goal is to provide you with as many questions as possible. You will notice that every single one of our slides has the exact same format. This is to parallel what you will see come test day for step 1. Let's look at question 1. And before you do anything, I want you to notice how long the question is. Now, questions typically range between, a few sentences to almost a paragraph, plus maybe lab values or a picture. On occasion, I believe on my test, we had 2 or 3 heart sounds. You'll be using a separate headphone for that. We won't really be giving you too much exposure to that here, but we will give you exposure to 99% of what the questions will look like. So you could read the entire question, then the answer choices, and then waste your time rereading the question because you didn't know what to look for in your first go around, or you could use our method. So what we recommend is that you always begin with reading the last 1 or 2 lines of the question stem, and then reading the answer choices, and then reading the whole question, zoning in on any relevant keywords. Now, you may not be trained yet to identify specific keywords that will help with the questions, so we will help you for the first few examples, and over the course of the series, we will slowly wean you off of any of our help, and this will become more natural for you to do on your own, and then come test day, you'll be doing it without even thinking about it. So we've highlighted for you the last 2 sentences of the question stem, so let's read it together. She states that when she goes outside or is away from the house, her symptoms improve. Physical examination findings are remarkable for boggy and violaceous turbinates. This type of reaction is most similar to which of the following? Let's read the answer choices. Anaphylaxis, Goodpasture syndrome, contact dermatitis, acute pharyngitis, or post-strep glomerulonephritis. Okay, so we're going to keep this in mind. We're looking for some sort of similar reaction that's happening. Now we could read the entire question and zone in on keywords. Okay, so I've highlighted the keywords that we were able to pick out. So I'll give you guys just a quick second. So we highlighted rhinorrhea, difficulty breathing, sneezing, allergy to latex, away from the house and her symptoms improve, and boggy and violaceous turbinates. We'll go slowly from the first example and we'll just work our way through that, okay? So rhinorrhea with difficulty breathing, with sneezing, and allergy to latex. All that has to do is just tell you that the patient has atopia, right? They're prone to allergies, and when she's away from the house, her symptoms improve. So these allergies are environmental, right? That's what's implied from this. They're environmental allergens. So knowing that, some sort of atopic reaction going on. You don't need to even know the actual condition, you just need to know the general concept. So, in this case, what would match that? Well, what kind of reaction would that be? Whenever these questions talk about reactions, they typically talk about hypersensitivity reactions. So maybe let's shift our focus towards that. Well, anything that has difficulty breathing with rhinorrhea, sneezing, and it improves when you're away from the source is just a normal type 1 hypersensitivity allergic reaction, right? That's the one that we get wheals and urticaria. So, one other way to say this is essentially anaphylaxis. That's usually a more severe form, but that is a type 1 hypersensitivity reaction. Let's see if there's anything else. Goodpasture syndrome is a type 2 hypersensitivity reaction. Contact dermatitis we know is a type 4. Acute pharyngitis is an infection. And post-strep glomerulonephritis is a type 3 hypersensitivity reaction. So if you're actually able to pick up on that they were asking about hypersensitivity reactions, you already had 90% of the question done before you even read it. Right after you finished the answer choices and you were able to pick up on that, that's a huge deal. Okay, so the answer is A, anaphylaxis. And once again, it's because atopia, you could think of as the generic allergy. That generic allergy is a type 1 hypersensitivity. And if it's not treated, it could lead to anaphylaxis. So I've included this slide to serve as a high-yield shortcut for everything hypersensitivity related. If you see a puffy patient with their breathing affected, it's going to be a hypersensitivity type 1 response. If there's an antibody that targets a specific receptor or a specific cell, it will be a type 2 response. If it's antibody or autoimmune mediated, but it affects the kidneys, it's most likely going to be hypersensitivity type 2 or type 3. The way you could differentiate between 2 and 3 is 3 usually has joint pain with redness, or it's post-infectious. If you want to actually know, type 3 is just deposition of antibody-antigen complex, while type 2 is the actual antibody messing with tissues or cells in the body. Okay, and type 4 is probably the most common on the exam, I think, that's asked. It's a T-cell mediated destruction of tissue. So let's move on to question 2. I want you to approach this the exact same way you approached the previous question. So I want you to read over the last 2 lines of the question stem, look at the picture, and then read through the answer choices. Okay, and I want you now to read over the whole question, and I want you to pick out the keywords. So we bolded some keywords that we found, specifically that the bullae are flaccid, that when you rub on the skin, it results in exfoliation of the skin layers above. That's just essentially saying that the tissue keeps separating every time you rub. Anti-immunoglobulin antibodies, so we kind of know that it's some sort of immunofluorescence, autoimmune condition. Okay, and then when we saw the answer choices, we saw it's really between 4 things: bullous pemphigoid, Goodpasture syndrome, scleroderma, and pemphigus vulgaris. So we're not here to cover content, but if it's in the question, we will cover the content that's necessary. So if the bullae are flaccid, that pretty much tells you the condition itself. You know it's an autoimmune condition. You know that when you rub on the skin, that blisters will form elsewhere, vesicles will form elsewhere that will essentially just blow up and secrete fluid. And the bullae are flaccid, so that they're capable of essentially being popped, right? So which condition is this? Well, let's look at the immunofluorescence for a second. This is what's called a reticular net-like distribution of immunofluorescence. This is actually a hallmark of this condition, and I don't want to give it away quite yet, but let's go from choices A to F. Okay, so bullous pemphigoid, what would that look like in an immunofluorescent picture? And then we could talk about the clinical picture. In immunofluorescence, you will see pretty much just one line, one continuous line of green highlighting one layer. Right, because bullous pemphigoid is an autoimmune condition that targets the hemidesmosomes, that anchors the basalis layer to the basement membrane. Further, if you want to look at the clinical aspect of it, the bullae are tense. They're non-flaccid, they won't erupt, and rubbing on the skin will not result in exfoliation of the layers above. So we know that it can't be bullous pemphigoid. So A and B are out of the running. Now let's look at C, Goodpasture syndrome. Goodpasture syndrome has to do with autoimmune antibodies against the basement membrane. So like we said before, we would expect an immunofluorescence that would be a straight line across. But you have to remember also that Goodpasture has to do with alveoli, glomerular basement membranes, right? Both of those basement membranes, both the glomerulus and the alveoli, is what's targeted in Goodpasture syndrome. So you'll have hemoptysis and hematuria, neither of which is seen in this patient. And we're talking about the skin. Goodpasture does not have a high association with any skin lesions that are described as such. Scleroderma, while this has nothing to do with any immunofluorescence in terms of the skin layers, it also doesn't have to do with bullae forming. This has to do more with sclerodactyly and thickening of the skin and tightness of the skin. So we're left with pemphigus vulgaris. So now we have to actually know a fact about pemphigus vulgaris. What is the autoimmune antibody? It targets desmoglein 3, right? Because that's the desmosomes. It's between keratinocytes, which are the little round structures that we see scattered about in this picture. So if you want to be a little bit of a gunner, you can know that desmoglein 3 actually is in a higher concentration, a little bit more deep in the skin, and as we go superficially, it decreases in concentration. So if you really want to be a super gunner, 280 brain, you will see that it's more green towards the bottom, and as we go towards the top, it becomes a little bit less green or a little bit darker. Let's look at question 3. So we're going to do the same thing we did for the last 2 questions. I want you to read the last 2 lines of the question stem, then the answer choices, and then the question. So we highlighted webbing of the fingers, toes, and the creases of the wrist, that the pruritus is worse at nighttime, that these burrows are serpiginous, and that they're asking about what layer of the epidermis that's affected. This is essentially just a second order question. You need to identify what the organism is, that's the infectious agent, and what it burrows into, essentially, what layer it burrows into. So, webbing of the fingers, pruritus worse at nighttime, and serpiginous burrows is usually scabies. That is a hallmark characteristic of scabies. That is how boards always presents it. They may leave out one or two of these facts, but it is always presented like this. The next fact you need to know is that scabies invades the stratum corneum. Question 4. Now, this is another question that Step 1 and Complex Level 1 love to test. So let's go through this just like we did the other questions. Read the last line, or the last 2 lines, then read the answer choice. Okay, we can read the whole question now. And this specific question was put in here to highlight the fact that sometimes the question itself really doesn't have to do with most of the question stem. So if you would have read it the first time around, looked at the answer choices, and then gone back because you didn't catch the information the first time around, you would have wasted double the time on one of the most important exams of your life. And we don't want to do that, okay? So we highlighted here that as the patient's age increases, the skin becomes more wrinkled. Now, you do have to know a little bit of biochemistry in order to answer this question. And if you don't know, well, then this is actually a very good learning point. So let's go through the answer choices. Collagen fibril synthesis increases with age. This actually is false. It's the opposite. Collagen fibril synthesis, or overall collagen, decreases with age. That's why elderly people typically have thinner skin that's more prone to breaks and lacerations. Type 4 collagen decreases with age. This has nothing to actually do with wrinkles. There is a loss of skin cells over time with age. I mean, we have stem cells in our skin. It's in the basalis layer. So we're constantly regenerating skin cells. So that doesn't really have much of an effect in terms of forming wrinkles. Collagen cross-linking increases with age. Now, you might not necessarily think that this would increase wrinkles, but it does. Collagen cross-linking basically acts to contract the collagen a little bit. It doesn't make it stronger. It doesn't make it, better able to do its job. It just forms creases in the skin. So what you should know, 2 big takeaways from this question are that collagen fibril synthesis actually decreases with an increased age, and collagen cross-linking increases with an increased age. They love testing this concept for some reason, so now you know. Okay, question 5. Let's look at the next question. Read the entire question, and I want you to pick out your own keywords. Okay, and the keywords that I picked out was a farmer, the rash that always comes back, and sandpaper-like rash with occasional scaling. Now, why do we choose these words? Well, a farmer works out in the sun, presumably. In terms of the test, you always want to assume that the farmer works outside, so there's sun exposure. The rash always comes back, even if it was treated and went away. And it's sandpaper-like, with occasional scaling. So these are hallmark descriptions for actinic keratosis. And actinic keratosis is a precursor lesion to squamous cell carcinoma. Very, very high yield. I would definitely commit that to memory. So if you ever see a farmer with a rash that comes back and it's sandpaper-like actinic keratosis, that can lead to squamous cell carcinoma. Okay, so this is a quick question. It's only 3 sentences. So you could read it entirely, and then go to the answer choices, and then maybe just highlight keywords and answer from there. Okay, so the keywords we were able to get were 8-year-old boy with hematuria, and clinic 3 weeks ago, penicillin for a rash. We want to describe the rash. That's the whole point of this, right? So an 8-year-old boy with hematuria, you want to think of either IgA nephropathy or post-strep glomerulonephritis. That's always your differential for a young boy who was recently sick, right, because he was treated with penicillin, and presents with hematuria. Okay, so what is the rash associated with post-strep, right? So what's associated with strep? You're probably screaming at the screen right now, impetigo. Okay, so that's the first jump. Let's do the second jump. How would you describe impetigo? Would it be white with an erythematous base? No. That's usually the description for a couple of different ulcers. It could also be for a Koplik spot. It could be for a few different things, but it's not what we're looking for. Circumferential rings of erythema separated by a pale zone? No. Right, that would be like erythema multiforme. How about gold crusted with vesicles? Yes, and if you've ever stepped foot in a clinic and you've seen somebody with impetigo, it does have a very golden crusted look to it. So that's going to be the answer. Maculopapular is used to describe a bunch of different rashes. So it's usually not going to be the correct response. If it's a shared characteristic amongst many different things, boards doesn't typically like to test things that are common amongst different diseases. Okay? So the answer would be gold crusted with vesicles because that describes impetigo, because an impetigus infection could lead to post-strep glomerulonephritis even if you are treated with penicillin. I included this slide just as a high-yield overview of some commonly tested rashes. So if you see gold-crusted rash or something with vesicles and gold crust, I want you to think of impetigo, usually due to group A strep. If you see vesicles in a dermatomal pattern, I want you to think of VZV or shingles. If you see erythema with or without vesicles in the shape of a necklace or a belt buckle, I want you to think of contact or nickel dermatitis. If you see a patient with classic atopia signs such as asthma, allergies, high eosinophils, with dry erythematous skin, usually in the flexor muscles, I want you to think of atopic dermatitis. If you see a rash with erythematous borders, you have to distinguish between tinea, which is also ringworm, or candida. And you do this by seeing if there's central clearing. If there's central clearing, it's tinea, and if there's no central clearing, then it's a candidal rash. This is going to be the last question of this video, but don't worry, we have plenty more dermatology questions that we've come up with for you guys. We'll make sure that you get plenty of practice and you feel very comfortable with dermatology as a topic, okay? But for now, let's focus on this question. I want you to employ the method all on your own, and then we'll show you the keywords that we highlighted. You see if you agree with us, and we'll just talk about it, okay? So the keywords that we highlighted was that the patient's a 2-year-old infant, right? So this thing affects kids. Erythematous nodules on the skin and has oral ulcers. The skin has several lytic lesions. And the question itself is the cell that contains the features seen below in the picture activates which cell type? So if you're a gunner or you just read first aid or you just finished the topic, well, congratulations, you probably found out this was Langerhans histiocytosis, but that really won't help you all that much. You kind of have to just know the general function of the cell. And this actually has, I believe it was on a few NBMEs. And even my friend did say that this was on her step 1 examination. So what are we looking at in the picture? Well, this is a Burbeck granule, right? You see this tennis racket kind of shape going on? That's a Burbeck granule. Those are only found in these modified dendritic cells called Langerhans cells. These are of neural crest derivative, and their function is to activate T lymphocytes. So if you knew that and you're able to identify it, then good on you. You didn't have to know anything about this patient's clinical presentation. You just had to be able to identify a Burbeck granule, know that that was a Langerhans cell, and that Langerhans cells activate T cells. So I just wanted to summarize. Pretty much the entire method is optimize your time. You want to read quickly and effectively. And in doing so, you're going to get a lot more points, and you're going to save a lot more time, which for the more mathy questions, if you have any mathematics on your exam, I fortunately didn't have that much on, but I did have some hard questions or some really long question stem questions. And those take time to actually address. So if you employ this method over a couple hundred questions, then you're going to be building up a lot of time in reserve, and you can use that for the harder questions. And as promised, I have included a list of free content review sources that I've used and that I found very, very helpful. I would highly recommend you check any of these out. The biggest time commitment would be the Anki flashcards. I believe Anking or Zonki, either one of them, it's somewhat between like 15 to 25,000 flashcards. It's a lot of content. Some of it's low yield. You're not going to be testing all of it, obviously, but you have to know everything for this exam. Dirty Medicine, formerly known as Dirty USMLE, comes up with very memorable mnemonics, and it's a pretty quick and easy way to learn some concepts, or at least how to answer some of the questions pretty quickly. Golion is podcast. If you're able to find the audio podcast, I know sometimes they're on Spotify, sometimes they're not. I would highly recommend it if you're able to get your hands on them. Just download them, keep them in a Dropbox or something, or on your desktop, and just listen to them while you work out. He's very good. He puts things in very simple terms, but these are very complex mechanisms that he's talking about. And he just pretty much tells you all the high yield that boards wants you to know. I've also listed all of the subtopics that were covered in this video. In case you had any sort of knowledge gaps or you felt as though you had any weaknesses, I would highly recommend that you actually do a little bit of content review on anything that you felt a little iffy on. All of these are relatively high yield. They show up on every board examination, and there's no reason for you to not get it. Overall, hopefully the method is starting to become a little bit more fluent with you. This is only the first video, so maybe give it a few more videos before you start really seeing results. But you will be getting faster with it, and you will be getting a lot more points on your practice exams and the real deal. All right, well, that's it. Thank you very much for joining me, and I will see you on the next episode of Quick Steps.